So in the next 19 minutes, we're going to go over vasopressin, AVP production, regulation, mechanism of action, AVP receptor, V2 receptor, mainly V2 receptor tolvaptan-mediated signaling, role of AVP V2 receptor in several pathophysiological conditions, and approved clinical use of AVP. So first, AVP production, regulation of mechanism of action. And we knew AVP is mostly produced in the meganocellular neurons in the hypothalamus, travels all the way down to the posterior pituitary gland. Its secretion is signaled by mainly osmolality change, increased osmolality or decreased volume. Increased osmolality is a highly sensitive but less potent response as versus volume deficiency is less sensitive but highly, highly potent. You almost have to reduce the volume by over 10% in order to activate the AVP production. And recently, it's becoming more and more clear there's a circadian rhythmicity of AVP, which is independent of osmolality change and the volume change. AVP secretion peaks at the midnight, nadirs at around noontime to help us regulate the water. And prior to sleep, recently, there's very good evidence showing there's an anticipatory AVP production mediated by vasopressin V1 receptor inducing a water drinking before we go to sleep to prevent the nocturnal hypovolemia. And this is an anticipatory fluid drinking, which is independent of osmolality and volume status. And recently, just we have FDA in US approved the using of a V2 receptor stimulated desmopressin to increase its boost of AVP at night to treat the nocturnal polyuria. In terms of AVP receptors, we have V1 receptor. V1A is highly expressed, almost ubiquitously expressed, but mainly in the vasculature, regulate the vascular contractility. V1B receptor has a lot to do with the pituitary habit-forming reaction, and V2 receptor mainly in the collecting duct and the thick ascending limb of Henle's in the kidney, and we will focus on the V2 receptor. V2 receptor it's very well known. We have the molecular informations, all molecular informations of AVP V2 receptor. Activating loss of function mutations has been identified in multiple spots associated with actually causing nephrogenic DI, and activating gain of function mutations are also being identified causing a hereditary SIADH. In terms of mode of mechanism of action, vasopressin activates adenylyl cyclase, elaborates cyclic AMP and PKA, which mediates redistribution of aquaporin-2, not only redistribution, but also increases aquaporin-2 transcription as well as aquaporin-2 translation. And recently, there's also very good evidence showing PKA through EPAC contribute to the stimulation-induced intracellular calcium elevation. Also, importantly, there is vasopressin in this also stimulate the renin release in the JG junction. It also stimulates mesangial contraction and promote the mesangial proliferation. This is some information related to vasopressin V2 receptor stimulation-induced the calcium surge in the intracellular cytosolic calcium concentration. And interestingly, tolvaptan, which is a V2 receptor blocker, could eradicate this intracellular surge. And during the resting state, without the vasopressin V2 receptor stimulation, the exposure of tolvaptan will increase the resting intracellular calcium concentration. So you have this dual effect. Under stimulation, it inhibits stimulation-induced calcium surge, but in the resting state, you could have increase the resting intracellular calcium concentration. And it hypothesized these changes has to do with reducing stimulation-induced cyclic AMP and increasing the phosphodiesterase so that tolvaptan would reduce the resting state cyclic AMP in the intracellular concentration. And cyclic AMP and the calcium reaction is directly related to the AVP phosphorylation and the cell surface AVP distribution. These were coincident with human patient experiments. If you give tolvaptan, there's a significant decrease in urinary aquaporin release. But we come to realize that so vasopressin V2 receptor signaling has much more than just regulating water. It also enhances the sodium chloride activation, sodium chloride absorption, also increases urea recycling, and stimulate calcium excretion. And in the thick ascending limb of Henle, it stimulates NKCC2, RAMK, basolateral CLC channel, and urea cycling at the medullary section. In the distal convoluted tubule connecting duct and collecting duct, there's effects on enhancing NCC, ENaC, RAMK, as well as CLC channel, all to build up a medullary hyperosmolality that facilitate the osmotic water diffusion. And these are having significant effects on rats experiments as well as human in the patients who has a high concentration of urine and a higher level of AVP stimulation. Their sodium excretion in the urine is much less compared to low urine concentration. And when the AVP level is low, all the patients are treated with vasopressin V2 receptor blocker. So vaptans are a group of molecules, a non-peptide, a very stable vasopressin blocker, vasopressin receptor blocker. And we have a V1A blocker, V1B blocker, V2 selective versus non-selective V2 receptor blockers. If you're looking at their selectivity, the most selective group would be tolvaptan, lixivaptan, and stavaptan. If you're looking at their binding capacity, the most avid binding capacity of aptans, tolvaptan and the lixivaptan. So based on these characteristics, most studies are using tolvaptan as a V2 receptor blocker to look at the V2 receptor-mediated effects. I just wanted to say the V2 receptor tolvaptan has an affinity several-fold higher than the native AVP. So even at the presence of AVP, tolvaptan could still block the vasopressin V2 receptor. So next, we want to quickly look at the role of vasopressin V2 receptor in several physiological conditions. In the SIADH is much more established, so due to the time constraint, I wouldn't elaborate on that. But let's look at the congestive heart failure and cirrhosis two conditions has salt retention as well as water retention. If you're looking at the heart failure animal model, even at the compensated states, there's a significant increase in end diastolic pressure, 4.1 versus 7.2. During the compensated state, there's further increase of end diastolic pressure, decreases serum sodium, increase the heart weight, increase kidney weight, and the mean arterial blood pressure is reduced. Under that circumstances, and we knew from the animal experiments as well as the human cell-based experiments showing there is significant renal increased production and upregulation of vasopressin-2 receptor, uniquely activated. Significant activation could be subdued by treating the patient with candesartan. And these are the candesartan results, and mainly to when you inhibit the RAS-mediated effects, you can reduce the aquaporin-2 effects in congestive heart failure patients. Also, congestive heart failure model has shown significant sodium retention, which is consistent with known effects of AVP conserving sodium. Well, theoretically, blocking the vasopressin-2 receptor signaling makes good sense for congestive heart failure, but unfortunately, all these studies has not shown any long-term beneficial effects. The largest study was published in 2017, Everest study, looking at the short-term as well as long-term effects. And in short term, there's a less dyspnea on day one of treatment, but there's no long-term mortality or rehospitalization benefits. There's at least several hundred studies on this subject in the last 15 years, and more or less shows the same thing. This is a recent meta-analysis, again, looking at all the reputable studies. There's a significant weight reduction, sodium concentration increase, but there's no mortality significance. So V2 receptor blockade in heart failure has not shown much benefit. This is these are more recent two trials. One is a secret CHF trial. Another one is the tactic HF trial. Both trials are very well designed, a randomized double-blind study, 250 patients in the secret CHF trial and 257 in the tactic congestive heart failure trial. Again, we don't have the time going into detail, but it's, again, negative results. There's significant weight reduction, sodium excretion for patients who received vasopressin tolvaptan, but there's no effects on dyspnea, no effects on any other outcome. So in general, tolvaptan in congestive heart failure, short-term effects mainly reduce body weight, increase urine volume, increase the serum sodium, but it's overall safe. There's only one single case of osmotic demyelination, but the rest of the side effects is pretty benign. No effects on over-cause morbidity, mortality related to congestive heart failure, nor any difference in hospitalization. And two recent trials we just talked about, there's not even an effect on dyspnea, despite the weight loss, despite the increasing serum sodium and increasing urine volume. So in the patient with cirrhosis, and this is way back in 2002, we knew the tolvaptan V2 receptor antagonist has the effect not only on the water excretion, but also increases sodium excretion, increases potassium excretion, and manifested along with aquaresis. But the rest of the studies are very non-impressive. And this is a recently published small study in patients with cirrhotic, with ascites, very low serum sodium concentration of less than 125, and 9 patients essentially didn't make any much difference. And this is another study has just recently published. This is a study from China, a small study of cirrhotic patients, short duration of treatment. There was some effects, but in general, the results for patients with cirrhosis has been mixed. And because of the adverse effect and the cost, we have not been using it. It has not been advocated in the clinical use. Tolvaptan use in ADPKD is probably much clearer and non-equivocal. There's really a good benefit consistently across all the published studies. Basically, in ADPKD, there's a fast decline of GFR demonstrated in the QUISP study way back in 2008 or the natural history. So in the patient with ADPKD, if their urine is more concentrated, they tend to have a faster decline of GFR. But if you make them drink more water, it tends to associate it with a lower rate of decline of GFR. That prompted the tolvaptan study, which in the Tempo 3.4 showed a significant benefit in terms of retarding cyst growth and retarding decline of GFR. And this was further confirmed in the recent Tempo 4.4 trials. So in the ADPKD, there is a benefit of retarding cyst growth and retarding, to an extent, CKD progression. And this is another interesting observation in patients with ADPKD. And apparently, urine monocyte chemotactic factor is parallel to the CKD progression, and it's almost a marker for worsening CKD. And in the people with non-ADPKD control group, and there's a very low urinary MCP1, but in patients with ADPKD, overall, they have a very high rate of chemotactic factor. More importantly, when these patients are treated with tolvaptan, there's a significant reduction. There's a significant reduction in this chemotactic factor across the board at the CKD stage 1, CKD stage 2, and CKD stage 3. That's correlated with a retarding CKD progression. So in ADPKD, there seem to be a good effects. But that segues to the proposed effects of AVP V2 receptor on CKD progression. And way back in 1999, experiments has shown using genetic rats lack of AVP, which is a Brattleboro rats versus normal rats, made 5-6 nephrectomized models in both groups. So the rats without AVP has much less compensatory hypertrophy, much less CKD progression compared to the wild-type rats with normal amount of AVP. So if you take these Brattleboro rats and give them V2 receptor agonists, DDAVP, and you can make these mice increasing serum creatinine much more so than the baseline, worsening anemia and worsening renal urine proteinuria. So there's a potential mechanism proposes that AVP through V2 receptor activation would cause glomerular hyperfiltration, hypertension. This seems to be unique going through vasopressin V2 receptor. AVP stimulation also known to activate the renin RAS cascades, which could also initiate the RAS-mediated long-term effects. AVP exerts direct effects on the mesangial cells, causing mesangial cell proliferation and contraction, which could potentially be another element that contribute to CKD progression. However, having said that, a human study is really, it's a mixed bag of small studies with methodological difference, confounding factors, and stage of CKDs. We really don't have a good conclusion. And so in terms of AVP effects in human CKD, we need more study. So with regard to the hypertension, it is a very well-known AVP through V2 receptor action could trigger a salt-sensitive hypertension. This is, again, rats lacking AVP versus normal, so rats lacking AVP. If you give them V2 receptor agonist DDAVP, there's a significant upregulation of ENaC. And this upregulation of ENaC is translated to the development of salt-sensitive hypertension. And the effects is amplified if you give the AVP plus the DOCA, which is a mineralocorticoid steroids. If you give DOCA and the AVP, the effects is synergizing, has a huge hypertensive effects. But we knew in human, salt-sensitive hypertension is much more complicated. It related to multiple signaling cascades involving a number of mediators, and probably AVP is contributing to a part of signaling. So in summarize, AVP and V2 receptor contributing to all these factors in theory and in some animal models. In ADPKD, we have very good human data showing that the AVP V2 receptors contributing to disease progression and blockade has some salutary beneficial effects. SIADH, of course, there is a demonstrable effects from vasopressin V2 receptor blocker. So approved clinical use so far is SIADH. So SIADH is approved use in USA, in Europe, and in Japan, and also in Canada. But it's not the first line use. It's after you exhausted all types of other medication, and should be no more than 30 days. Recently, for ADPKD, it was approved by European medication agency to use it in a more aggressive type of ADPKD, and this is their position paper. So due to the time, so the key point is AVP has vasopressin V1 and V2 receptor. They have different signaling cascades. Vasopressin V2 signaling affect not only cyclic AMP, but also intracellular calcium. Intracellular calcium amplifies cyclic AMP-mediated effects. Involved in multiple pathological processes, it regulates not only water, but also sodium and potassium. There's implication in the hypertension. And vasopressin V2 stimulate renin production and mesangial proliferation. There's implication in CKD progression. Tolvaptan may be used in SIADH and the aggressive type of ADPKD in certain countries, in Europe, Canada, Japan, but not in USA. And tolvaptan has limited efficacy, as far as we knew, for the patient with congestive heart failure and hepatic cirrhosis. And we need more study to clarify these potential benefits or detrimental effects of vasopressin V2 receptor and the beneficial effects of a blockade.